Hi, good evening, ladies and gentlemen. This is your friendly neighborhood ophthalmologist, Sashwat from Medway platform, and I'm here to discuss the NEET-PG questions which people faced on Sunday in two different sessions. Um, I'm sorry for my voice. I hope you can all hear me, but I hope you can hear me. But the fact remains that it's not very good because I have been taking classes for a long time. So I hope you'll excuse my husky voice. Gentlemen, so the questions that we've been able to get, the questions that we have been able to get this time is like this. So I found them good because they're mostly clinical. And as a clinician, I find it always good that when you give clinical based questions rather than obscure syndromes and matters of obscure ophthalmology, because I don't really think that PG entrants should be asked to such difficult questions, because if they could answer it, that they wouldn't require a post graduation. However, this is my own personal prejudice, so we can't do anything about that. So let's look at these questions, and I hope you've all done well, each and one. I all really hope you've done well, because you are the future generation of doctors who are going to take care of this country, this sad, bad country. Very well. So, muscle responsible for the ptosis in Horner syndrome. We have orbicularis with levator palpebris superioris, Horner's muscle, and Mueller's muscle. This is a simple one because, my gentlemen, the ptosis, if you know, first of all, that the Horner syndrome is diagnosed as, you have to remember, diagnosed as OSP. It's not the Horner syndrome. We call it as, memorize it, OSP. What is that? Oculosympathetic paralysis. Now, this is something I want to tell you, share with you, that this is a memory trick, So then sometimes when you're trying to learn something and it's a long word, 4 words, 5 words, it's sometimes easy to memorize it if you just memorize the initial letters. Instead of remembering oculosympathetic paralysis, if you just wrote OSP, it helps you immensely. At least it does me. So there's a little tip for you. Maybe it'll help you too. So oculosympathetic paralysis, that means the sympathetic system of the eyes have got paralyzed. Multiple reasons, as you know, Pancoast tumor, then you have dissection of internal carotid artery, Wallenberg syndrome, so on and so forth. But this does not, and question is not based on the causes. It says to diagnose Horner's, kindly remember, and I'm sure you all know this, we require 3 things. Ptosis, you memorize as P, M, A. Okay, what's that? P for ptosis, so there's ptosis. M for meiosis, there's pupil constriction, and anhidrosis, inability to sweat. So these are the 3 things. I mean, there are many others. You have heterochromia, and you have low intraocular pressure, you have apparent ophthalmos. But remember, for diagnosis, we just need these 3. In fact, they were the original criteria which Horner's used. The original Horner who made the diagnosis, he uses only criteria. The rest of the things were discovered later. So we need this. This ptosis is minimal. If you see here, so in this picture, there's minimal ptosis, is not? So why is this ptosis so minimal? Because the paralysis of the muscle which causes ptosis is not the levator palpebris. If it was LPS, it would have got complete ptosis, because LPS is the principal elevator of the eye. So the Mueller's muscle, beg your pardon, is the answer here. The Mueller's muscle is supplied by the sympathetic plexus, and that gets paralyzed, and that is why there's a mild ptosis. Okay, mild ptosis for Horner syndrome, because the Mueller's is responsible for opening or elevating the eyelid only 2 millimeters. So it's the Mueller's muscle which is the answer, and I'm sure all of you got it. Right? What is Horner's muscle? Have you heard of this Horner's muscle? Horner's muscle, remember, is a part of the orbicularis and is responsible for the lacrimal pump. You know that for the tears to drain down from the lacrimal gland, which produces into the nose inferior meatus, there's a lacrimal pump here. And this muscle, the Horner's muscle, is a part of the pump. So kindly remember, it's a small part of the orbicularis itself, which is called Horner's muscle. And sometimes if you get a question, lacrimal pump failure, you can answer Horner's muscle paralysis. Okay, very well. I hope you all got this right. Next question. Any comments? You are welcome here. If those of you are, of course, watching here live to me. No live, no problem. Second question. Following perimeter image is suggestive of, beg your pardon for the spelling mistake. So this is, as you can see, is a Humphreys perimeter. It's a static is a what we call is a automated perimeter, static perimeter. And so what is this that you see here? We have the enlargement of blind spot, arcuate scotoma, Ron's nasal step defect, and altitudinal hemianopia. So if you see, these are the two blind spots. Okay, remember, in a static perimeter like Humphreys, the two dark areas are two blind spots. So that means these are the two temporal areas. Okay, remember the blind spot always lies temporally. Why? Because the optic disc lies nasally. It's always opposite, remember. So the fact that these are the two blind spots, they give us the orientation of the visual field. So the two blind spots, these are temporal, so this is the temporal side. So our orientation tells us that this is the temporal field. There's something wrong with this pen here, let me see. Dear me. And this is a fine start. And so temporal, this is the two temporals area, so the temporal is. So what we see here is a blind spot and something on top of that. So obviously let's apart from the obvious answer, which is enlargement of blind spot, this is the obvious answer. Why is this the obvious answer? Because this is the obvious answer because you can see that the blind spot, the location is right on the blind spot here, the enlargement of the blind spot. I'm so sorry, the pen seems to be malfunctioning. So we need to, we'll just see if we can get this. So this is the I hope it works now. Yeah, thank you very much. And so this is the blind spot. But let's see if we can just for fun, let's see if we can do that. Could it be arcuate scotoma? No. Arcuate means it will have some arc shaped. So you will see the gray scale here, there's no arc shaped. It cannot be an arcuate scotoma. Could be nasal step defect, which is seen in glaucoma. Incorrect, because remember this is the blind spot, it lies temporally, so the defect is temporally. So this is nasal step would have been here. Could it be altitudinal hemianopia as seen in AIO and anterior ischemic optic neuropathy? No, because altitudinal hemianopia would be half the field would be lost, right? So the answer is what we said in the first. This is the two blind spots. It has to be enlargement of the blind spot. And where is it seen? Remember the most common, you have some other conditions also. The most common case where you have enlargement of the blind spot is the papilledema. Papilledema, raised ICT causing disc edema. So that has this enlargement blind spot where the size of the blind spot enlarges, and that is the most common visual field defect of papilledema. So I hope you've got that. Even if you do not know, just by looking at the field and knowing that these are the blind spots, you can answer some questions, and I hope you've done. If you haven't, I don't blame you, because if you know so much, you wouldn't need to take the PG entrance exam. Very well. The next question here is a patient present to the IOPD after 3 years of cataract surgery, and the slit lamp finding was given, as you see here, was like. So on the retroillumination on the screen, what you see is these weird things on the background. Okay, so they look like dew spots, is not on the retroillumination, and this is actually seen like this. Now, could be PCO, could be bullous keratopathy, phakic glaucoma, and lens subluxation. Okay, so what do you think is 3 years after cataract surgery and given these small whitish excrescences on the illumination, the best answer is PCO or a secondary cataract. Okay, posterior capsular opacification, also called a secondary cataract after cataract, and these are actually the Elschnick's pearls. The most common kind of a secondary cataract is Elschnick's pearls, and you all know why secondary cataract occurs, because the migration of the lens epithelial cells from the anterior capsule to the posterior capsule. Okay, so this occurs almost in 20 to 50% of cases of cataract. So it's a very irritating problem for us, the patients, of course, who just do not like it that soon after cataract surgery, again they have pingless blurring of vision. The answer should not be too difficult for ladies and gentlemen, should be PCO. Okay, cataract surgery, and this looks like a PCO. Though of course, if you want it to be a little more, it could always also look to be a bullous keratopathy after corneal decompensation. But to my eyes, as I look at this picture, it looks more like a PCO than a bullous keratopathy. Though of course, opinions differ. The picture is not too good. It's a little grainy here. That's the answer, according to me. What about the next question? A patient came with nyctalopia, A retinal image is given below, and what will be the diagnosis? So this is absolutely standard. I think you should not make a mistake with this. This is called as you can see the pigments on the periphery here, and you can see this macular damage here. So this typically is retinitis pigmentosa. Retinitis pigmentosa, because you have the pigments on the periphery all clustered around the blood vessels, is retinitis pigmentosa. This is not vitamin deficiency. Vitamin deficiency would not appear like this. They have these creamish yellow spots, which comes to us as the XF, xerophthalmic fundus, is not. Retinal detachment, of course, doesn't work like this. You can see a grayish glow, and diabetic retinopathy, you would see the diabetic macular edema. So the answer is also given is nyctalopia. So night blindness, along with this is a classic condition of retinitis pigmentosa, and a horrible disease because there is no treatment of retinitis pigmentosa. Very well, that seems to be an obvious answer. Now, a patient presents to the IOPD with this finding. What is the diagnosis? And if you see what is the finding here, you can see on the inferotemporal limbus here. Look at that, limbus on the inferior side, and temporal, if this is nasal, is this weird nodule kind of a thing on the limbus. And this, do we have a choice? We have dermoid, lipodermoid, we have pterygiums, and pinicula. Straight away, pinicula and pterygiums are ruled out, so it has to be lipodermoid and dermoid. The answer is it is a limbal dermoid, choice A. A dermoid is good enough, but a better answer would have been a limbal dermoid, because dermoids can be present in an orbit also and in the limbus also. So limbal dermoid is the answer, choice A, which is seen often in a condition called as golden Haar syndrome. Where you have preauricular tags, a high arch palate, and most commonly this famous limbal dermoid. Okay, lipodermoid this is not what it looks like. It is more under the eyelids here, with a lot of fat prolapsing out. This is lipodermoid. Very well. So limbal dermoids, as in golden Haar syndrome, these pictures. So we see that this time the exam has been full of pictures. Full of pictures. This is what it is. So the next thing is a baby presents with hydrocephalus, diffuse calcification, and chororetinitis. DME. This is a classic triad. Remember, hydrocephalus, diffuse calcification, and chororetinitis. The answer is congenital toxoplasmosis. Okay, this is the classic triad. We have to memorize this. Congenital toxoplasmosis, you could be acquired also, which are mostly toxoplasmosis can be acquired or congenital, but congenital toxoplasmosis is a classic triad of this thing. So we don't have to look at the other choice at all, because the standard, absolutely straightforward answer. The next question is, which of these statements are true except? These statements true or except? And here, what we see here, what we see, this staring eyes, this proptosed eyes, where you can see that looks more like a lid retraction of both eyes rather than actual proptosis, because of the drawing back of the upper lid here, and lower lid, as you can see, is close to the limbus. So this is the classic condition of Graves' disease. Graves' disease, which is the most common cause of hyperthyroidism, the most common cause, which is autoimmune disease of the thyroid gland. So they are all true except. So we have to look what is the false one. The no specs classification could be used for this question, and that is absolutely correct. You all know the no specs, which starts no specs means N for no signs and no symptoms. The O becomes only signs, no symptoms. What are the only signs? That the patient is not aware of them, but only signs are lid lag and lid retraction. S for soft tissue signs, which are multiple soft tissues. You can have lid edema, you can have injection of the lateral rectus, insertion, you can have eyelid edema, you could have caruncular edema, lid swelling, you can have resistant retropulsion, So multiple soft tissue signs here, which are seen in thyroid. And that was S. What about P? P for proptosis, the condition when the eyeball pops out. Why? Because the enlargement of the muscle belly with sparing of the tendon, which pushes the eyeball out. There's no room inside the orbit for the eyeball, so eyeball comes out, caused bilateral proptosis. E for extraocular muscle involvement, which as extraocular muscles, they get replaced by fatty tissue or glycosamine glycans, so they get restricted because they can't contract anymore. So the first muscle is the inferior rector. You must remember the mnemonic, I am so lucky. Why am I so lucky? Because I have such wonderful students here. So inferior rectus is I M is medial rectus, SO is superior rectus, L is lateral rectus. This is the order in which the muscle is replaced. C is corneal exposure. Because of the proptosis, the cornea gets exposed to the atmosphere and you develop exposure keratopathy. And S is for loss of sight due to optic nerve compression. Okay, so these are no specs, that's correct. The 10% cases occur without systemic hyperthyroidism, and that is absolutely correct. Remember, approximately 10% is euthyroid. So these are patients euthyroid, they're not hyperthyroid, and yet they have goiter. Okay. Several cases finally to lead vision loss, that's also correct, because some cases finally the vision loss occurs due to optic nerve compression. So optic nerve compression because of the enlarged eyeball, and they lose vision. So these three are correct. So it remains that whatever leaves left behind has to be incorrect, and whatever it is, response to treatment is proportional to finding. Doesn't make much sense to me. I don't think this is the correct choice, but whatever it is, this is the answer, because the first three are correct and we need to know all are true except. So maybe until we get a better choice, response to treatment is proportional to finding, we'll stick with this. This is the true except. All of them are true. Next question, on clinical scenario about homocystinuria, which vitamin is to be supplemented? Now here we have thiamine, we have B6, we have B12 and pyruvate. The answer is B6, pyridoxine. Okay? Best answer, pyridoxine. You see why? This is a question of homocystinuria. So we are talking about homocystinuria where you know the CBS enzyme is missing most of the time. Cystathionine beta synthetase. Cystathionine beta synthetase. So this is the enzyme which is missing here, homocystinuria. So it allows the homocysteine to collect into the blood. The homocysteine collects in blood and effectively it drains out through the urine, causing homocystinuria, which causes a lot of syndromes in ophthalmology like subluxation of the lens. From homocystinuria, you have subluxation typically in the infranasal quadrant of the eyeball. That is one. They are very tall and they are very pectus chest, and sometimes they are mentally retarded. So homocystinuria occurs because of excessive collection of homocysteine and methionine in the blood. This is because of an enzyme deficiency called CBS rather, cystathionine beta synthetase. Now the answer here is what we're talking about is B6 pyridoxine. This is how when we give B6, then that way it protects from the body from the deleterious effect of the homocysteine which is collected in the blood and washed out in the urine. Okay, the answer is B6. A 2-week-old baby presented with vomiting, acidosis, early cataract. Okay, so as soon as they come to us with vomiting and as soon as early cataract, failure to thrive, we know that basically he's talking about galactosemia cataracts. Okay? So with the following examples, so galactosemia, which causes which causes a oil droplet cataract. Here galactosemia is primarily because of the absence of one enzyme or one defective enzyme. This is GALT, G-A-L-T. Okay, galactose 1-phosphate iridyl transferase. Okay, this is the most important enzyme which is defective, will lead to galactosemia. Okay, we don't have to look into galactokinase or hexokinase or aldose reductase. That's a simple memory one. Another one is a more difficult question about, and you can see the Wirtz 4 dot. Now, Wirtz 4 dot is often used for picking suppression along with anomalous correspondence and also with which glasses are working fine and which aren't. Now, look at this. So, you have a patient, image A. So, this is the image A. We have these 4 dots where one on top, 2 on the sides, 1 on the bottom, and along with image B. And image B that you see here is a red-green goggles, red-green glasses. Remember, red-green, the red is always in front of the right eye, the green is all on the left eye. So I put on this glasses, red-green, and this image C was visual. That means while after this was done, I was asked to focus on the image forward, and this is what you will get. So this is what we got. So what does it mean? Okay, look at that. In the Wirtz 4 dot, you have these 4 dots here, and the white here. So there's 1 red, 2 green, and 1 white. So, and we always wear the red-green goggles. Red is the right eye, left is the green. Okay. So red glasses put on the right. So it's RR, red in front of right, and the green is on the left eye. And wearing this red-green glass, always right that way and green this way, we look at these 4 dots. Now see what happens. When I wear the red glass, it can see only red. It blocks out every other light. Similarly, with the green laser or the green glasses, I can only see green. It blocks out the red one. So we have a combination of two greens, one red and one white. So when I see it with my right eye closed, okay, right eye closed, so what happens? I see the left eye. So left eye picks up the green, it picks up the green, but it cannot see the red because it allows only green light to pass through. And this white light is made of two, red and green. So it will say, so when you have right eye suppression, which means I'm seeing the left eye, so I should see the two greens and the third one green, I should see right eye suppression. I should see three spots, and this is actually the answer. So why? Because remember, when I close the right eye, so with my left eye, what am I seeing? The greens are visible. So I see this green, I see this green, and I see the third green, which is white, which is a combination of red and green. So I can't see the red, but I can see the green. And this, of course, will not be visible to me when I wear the red-green glasses. So this means the answer is going to be right eye suppression. Okay, right eye suppression, because I can see this. Now, if it was left eye suppression, the first part. In left eye suppression, that means the left is suppressed like this. With the right eye, remember it was the red glasses. So that means that these two greens will not be visible because red can see only red. So I would find this red and I would find this white, which is composed of green and red. So I will see two reds. So if I were right eye suppressing, I would see it like this. Okay. Why is that? These two will not be visible. So this is visible and this is visible. So this tells us the right eye suppression, the left eye. Suppose my left eye was suppressed, and the answer here is right eye suppression. But suppose just for a lark, let's talk about left eye suppression. So I left eye. So with my right eye, which was the red glasses, then what should I see? With left eye suppression, I will see this red, okay, and I will see a part of this which is also red, but I won't see these two. So this is how, when I see these two, I get a left eye suppression, but when I close right eye, I get a right eye suppression like this. The answer is right eye suppression. So this is a complicated exam and test for you people, but I don't blame you if you haven't done too well. Okay. Thank you very much, ladies and gentlemen. This is all that we have from Medway Online right now. And if you get more questions which we have not been able to procure, please feel free to write to us, and we'll get back to you immediately, because we have been collecting questions and trying to get all the questions that have been asked this time. Thank you very much and good night. Oh yeah.